possible reasons. You say one. Or in ICU or wherever, surgical patient, blood pressure is low, pulse rate is high. Sorry? Okay, patient may be dehydrated. Okay? You can hear me, no? Right? You can hear me? Right. Patient may be dehydrated. Dehydrated. So adequate fluid work may not give. Okay. In setup of maybe a large vascular surgery, maybe what? Or maybe a endocrine surgery like adrenal gland surgery, highly vascular surgery. What may be the reason? Bleeding. Bleeding. Or trauma patient, maybe bleeding. Bleeding injury, liver injury. So, bleeding. Okay? So, how you can generalize? Must be a hypovolemia. But in one other setup also you develop similar low blood pressure and tachycardia. Pressure is going down and pulse rate is gradually increasing. But the other situation, okay. One is hypovolemic shock. Whereas septic shock. Sepsis also will develop this. Understand? So same. So this is patient A, ICU ward, either hypovolemia or sepsis. Now don't wait until the blood pressure become 80-50. Previous day, fourth round or last night, fourth round, you know the blood pressure was 110, 80. Today morning, 170, you had to have a suspicion. Understand? Pulse rate was, yesterday was 80, today 110. Some problem. Okay, that's why in other countries, UK and things, they use the early warning score. National Early Warning Score. National Early Warning Score. News. Now they use modified early warning score known as news. I think we have to introduce that, isn't it? Board. You have to have at the pre-go. You can have a rubber stamp and you can say what was blood pressure yesterday, pulse rate yesterday, respiratory rate yesterday, temperature and DCS. Those are more than enough, and maybe you know. Okay, that is you pick up. Yesterday pulse rate was this, today's pulse rate is this. Blood pressure, do it now. Don't wait until the patient goes to the crash stage. It's very difficult to resuscitate. You can resuscitate, but there have been some residual effects, kidney effect. Okay, this is very important. As a doctor, when you are doing a ward round, you will pick up something. Patient face may be looked abnormal. Patient may be in a pain. One patient may be a bit agitated or confused. That's more than enough. Believe me, if you want to be a good doctor, pick up the complication early. Okay? Very important. Right? So that is A, patient A. Now patient B comes, BP low, pulse rate also low. Underwent APR, abdominal resection, and patient on the epidural. They said no ICU bed, they are sent to the ward. Or maybe patient was in ICU, now coming to the ward after recovery. Right now, you are doing a ward round, BP low, pulse rate is low. So what is going in your mind? What do you think? What will the reason? Patient on epidural. And nurse said, just now I have given she complained pain, I have given the epidural. It was okay, but when you are checking, this is what's the reason? It's a neurogenic, no? Yeah, maybe even increase intracranial pressure. What this is known as Cushing reflex. So in an elective patient, neurosurgery may be that. Maybe in a pediatric ward, some infection, maybe a meningitis with some abscess or cerebral edema, so then problem. In case of trauma, intracranial hemorrhage, maybe extradural or something. That is happening. Understand? So one is the other pattern, right? So it's an increase in intracranial pressure. Now you are getting in the patient, blood pressure also high, pulse rate is also high. Maybe in a medical ward, maybe in a surgical ward, maybe in the ICU, maybe in the A&E. Okay. So, what do you think? Patient may be anxious, right? So you are doing a ward round, a new patient. The senior doctors are not there, junior doctor is coming. Oh, this guy is going to kill me or something. Okay. So then anxious. That may be the reason. Okay. What's the other possibility? Any other possibility? Inadequate pain management, isn't it? Which is the pain. Not everyone will tell the pain outside. That's why pain is more subjective. They struggling inside. So they develop tachycardia and hypertension. So inadequate pain management, very good. What are the other possibility? You are in the medical ward. Or you are in the A&E now. Someone is coming, a female is coming with sweating, palpitation, erythematous face, and high blood pressure, 220, 140, and pulse rate is high. Can be a neurocytoma. Possible, no? Can be an anxiety attack. What is that? Panic attack. Possible. Okay? Right? Can be a thyrotoxicosis. Possible? Right. So all this will come here. So, of course, you can include the respiratory rate and GCS and urine output and temperature. Still, I can remember in my first medical appointment, Dr. Ananda Raja told me as a medical student, every day you see this blood pressure, pulse rate, respiratory rate, GCS, urine output, and temperature. This is more than enough. Don't think you have to be a very advanced doctor to detect these things. Okay, even though medicine is evolving, technology is evolving, but you have to know is a basic. You know these things, right? Patient will be one of this. So don't wait. That's why this presentation is talking about, right? Recognize patients' signs and symptoms early, right? If you miss that, then it's difficult, right? Especially old people, if they go to the late stage, very difficult. And the other problem is activation also, till the last moment, they will be active. And you will say, oh, he was acting and talking. No, suddenly they will crash. So young people, they will have lots of physiological reserve, so you won't see the signs and symptoms early. Old people, they crash, gone. So you know the importance of looking for the early signs and symptoms. Okay? No, it's very simple, right? That's why you all have studied what? Q so far. Isn't it? What is so far? Sequential organ failure assessment. Now very simple. If a brain is not getting adequate blood supply, what will happen? Disease will decrease. If a kidney is not getting adequate blood supply, what will happen? Urine will decrease. If your heart is not getting adequate blood supply, what will happen? Tachycardia or bradycardia or arrhythmia or something. Lung is not getting adequate blood supply, either tachypnea or low respiratory drive or something, and hypoxia. Very simple. So one of the organ failure, sequential organ failure assessment, is a big chart, so you can't remember everything. So at least you remember three things, isn't it? Three things are systolic blood pressure less than 100, respiratory rate more than 22, and the GCS less than 50. doctor, when you go around, systolic blood pressure is okay, respiratory rate is okay, ECS is okay, your patient is okay. At least one or two is a problematic, then you have to find the cause, especially in sepsis. Okay, so so far more important in the surviving sepsis campaign, isn't it? Sepsis. Okay, so recognize the signs and symptoms of surgical emergency. That's one thing I want to tell you. Okay, so all this is in yours, basically safe, right? And just remember, now, not always bad patients develop tachycardia. Sometimes they develop arrhythmias. We have seen so many times. There's a bowel leak. They develop atrial fibrillation. Okay, atrial fibrillation. So, not only the tachycardia, the sepsis, anything can happen. Temperature can increase, temperature can decrease. Pulse rate can increase, pulse rate can decrease. Respiratory rate can increase, respiratory rate can decrease. WBC can increase, WBC can decrease. Understand? Sepsis, anything can happen. Okay? Then another thing I have learned, but these are not in the book. Patient looks bad, CRP normal. Don't believe the CRP. CRP may increase tomorrow. Understand? Sometimes patient looks bad, CRP is 5. CRP takes time to improve. That's the one thing I have seen. The other thing I have seen, sometimes patient looks very well, CRP is 300. That means patient is improving. If you do CRP tomorrow, CRP will be 320. You will think, oh, no, it is coming down. But 300 becoming 400, some problem. So these are the things, you have to see the patient, not the investigator. Now the trend is what everybody is going for, the investigation. See the patient, treat the patient, not to treat the investigator. Okay? So this patient, all about what I have discussed. Okay? So vital signs, the basics. Again, same thing I have told. ECS will increase. What are the? And saturation again, this saying less than 90, but I won't wait like that. Because 92 is a problem for me. Why 92? Why 93? If the patient is a very good patient or healthy patient, why today is 93? It was 99 yesterday. That itself should raise your concern. And why the oxygen demand increasing? Some problem. Think. Right? Okay, so basically what we have discussed now. Different books say different thing, different guidelines say different thing, but you have your own thing, right? Right? Whatever is used so far or this one. Okay? So tachypnea, hypoxia, hypotension, right? ECS change and the pain. Right. So one more thing I want to tell you, you may be seeing recently we had few deaths in our operating theaters. Do you know what's the reason? So operation success, patient death. Okay. The reason for that is most of the doctors, surgeons, experts don't understand what is the priority. First priority is life. Okay. The next priority is the organ or limb. Then the function. Third one is the auspicious, cosmetic. And you see, you are going for a colostomy reversal. Patient is getting bad. You are doing about 6 hours, 7 hours, 8 hours surgery. Patient is bleeding and you have given lots of blood. What you have to do? Put the person back and tell the patient I will come out. Rather than try your maximum. I will revert this colostomy. I will find the other end. Right? 10 hours gone. I will somehow find the other end and fix it. You fix it and patient will die next time. Right? Not to ego is here. Patient is life, you can live with the colostomy. Understand? So think about it. Life first. Where are we now? Right? Or then, yeah, right. Example, patient bleeding, you couldn't control, lower limb is bleeding, you couldn't control. What is important now? Life is important. Do amputation and come out. You can justify. Now you do anastomosis and putting a graft, it is bleeding again and coming again to ICU and going to the board. Okay? So like that, okay, you are doing a patient on the trauma, are you going to do plastic surgery during that time and see the hospices? You have to decide. Just because you are in that field, don't think your field is good. Your priority is life of the patient. Most of the doctors, new generation, are not understanding this. I don't know why. Till you understand this, there will be lots of medical legal issues. Okay? So, same thing, very simple. Life, organ, function, hospices. I don't know, I have this listed on my mind. Maybe it should be in the books somewhere. But no one teaches this. Okay? So, vital signs and all this we have discussed. Right? Then other thing I want to say. So when you are discussing this, the important concept come damage control surgery. Damage control surgery. Okay, damage control surgery. Now, in a trauma or in a severe surgical complication, three things kill the patient. I don't know, you have discussed already lethal trial. Three things will kill the patient. One is acidosis, hypothermia, and coagulopathy. Severe sepsis, severe trauma, multi-trauma, something. These three are the killers. Lethal trial. Acidosis, hypoxia, coagulopathy. More time you give the stress to the patient, and more of this they do. Surgery itself is very stressful. I always tell the patient, surgery life is going for the war. War is going on to go. Surgery is like this. Major surgery means major war. Right? If you are not fit, you can't go for elective surgery. Urgent surgery is different. But if you are doing urgent surgery, life-saving surgery, think about these three. How you can reduce acidosis? How you can reduce hypothermia, coagulopathy? Do the surgery less, minimal, and come out quickly. This will kill the patient. Even this colostomy reversal patient ultimately develop DIC and coagulopathy and bleeding. Why? Long duration surgery and massive blood transfusion. Okay. More time, more problem. With acidosis, you develop hypertension, molecular abnormalities. So always think when you're doing surgery, cover the patient very well, warm the patient. Hypothermia will kill, especially these children, kids, and extremes of age, no fat. Think about it. So what we do in damage control surgery is, the patient coming with that massive bleeding. When you go open the tummy, liver is bleeding. You are doing things not controlling. What do you do? Pack. Put a pack. Come out. Not closing the abdomen. Just put few stitch of that abdomen. Because you will come up again in 48 hours. Cover with the polythene. Put stapler and send the patient to ICU. Right? Now bleeding is stopped. So the ICU they will give more blood, inotropes and everything. Patient will get better. Physiology is now good. 48 hours. Vitals are good. Now you take the patient to the theater. Remove the bag. Not bleeding now. Okay, fine. Close nicely and come out. Patient will go home. If you do liver resection and anastomosis, bleeding, massive blood transfusion, after surgery, patient will go to the mortuary. That's the principle of damage control surgery. You only worry about two things: bleeding and contamination. The contamination there, feces there, remove it. Do you want to bowel anastomosis? No. Just put a stapler and come out. You will do the anastomosis later. Just because bowel is not connected, patient not going to die. Remove the dirt. Stop the bleeding. Come out. within half an hour, 1 hour. No need to close the abdomen also. Put some few sticks and put the polythene and cover it, come up. Look at from outside, you can see the bowels and everything. Okay, that's a damage control surgery. Very important to understand. So, previously people thought massive trauma, massive right compartment syndrome or anatomical leakage. First OT, then ICU, then mortuary. Okay, now the concept is OT, right? Damage control surgery, OT, ICU, after 48 hours, OT, then the ICU, then home. Okay? So these are common sense damage control surgery. They are coming to life. Okay? When you teach a lot, you can't keep a lot. Another thing I have already told you. Frailty. Sometimes the patient comes 80 years old, but they are very fit people. So age is not matter. What is important is the fitness. Sometimes you get a 60 years old, very frail patient. Okay, so you think about the fitness, surgical fitness. Maybe a ASA score, ASA 1 or 2 or 3, or there are some frailty scores. So just think surgery is a war. Okay, make the patient, check the patient, the fit. The patient is not fit, to sit with the patient and family and explain and take a shared decision. Okay, so when I came in 2019, one of the VIP's father came with the renal cancer, is going to the IVC. He had an ejection fraction of 30, bronchiectasis, so he was 80s. I discussed with the family. I'm not going to surgery. Leave this. You will live for 1 or 2 years. But if I do a surgery on the table, you will die. It's not my decision. We discussed with the multiple team, anesthetists, experts, pathologists, patient, family, and take a decision. That decision is known as shared decision, not you take the decision. That's because you know how to do a surgery. Don't be a heroic surgeon. Okay? Summary, vital signs. Pick the change in the vital sign early. And damage control surgery is more important. Life is more important than the organ of